I make it 10 o'clock, so I think we'll get started. So a very warm welcome to today's online event on informed improvement even, from insight to impact, run by the Healthcare Quality Improvement Partnership. This session is scheduled to end at 12 p.m. today, and my name is Rachel Sample, and I'm your Associate Director at HQIP, who's hosting the event this morning. This is actually the last day of a really excellent week, and I thank you all for joining us during what has been an unprecedented heatwave. I'd also like to thank all of my fellow HQIP colleagues who have put in a lot of effort this week, but a special thank you goes out to our communications team, Celia, Fiona and Molly, who have put together what I believe to be the best Clinical Audit Awareness Week to date. Firstly, please note that this event is being recorded, and we really hope to be able to make both the slides and the recordings available on our HQIP website shortly. As you know, this event is part of Clinical Audit Awareness Week 2026, which has been a week-long campaign that celebrates and promotes the critical role of clinical audit and data in improving healthcare and, most importantly, improving the experience and outcomes for our patients. The campaign includes the Excellence in Clinical Audit Awards, which recognises individuals and teams who are transforming healthcare through rigorous clinical audit and evidence-informed improvement projects. A highlight of today's event will be a chance to find out about the winners of the Evidence into Practice Award and hear from them directly about their work. In addition to saying thank you to all for giving up your time today, I would also like to extend a warm welcome to today's speakers. This week across the 5 themed days, 2026's campaign has explored how insight has become action, showcasing practical examples, innovation and collaboration to support improvement across healthcare. Today's focus is on data-informed improvement, and on this final day of Clinical Audit Awareness Week, we focus on how we turn evidence into results, demonstrating how data-driven programmes can improve care and really make a lasting difference to patients and our services. Next slide, please, Celia. Before we start, a few brief housekeeping notes. All of our microphones will be auto-muted to avoid any background noise. We'd like everyone to keep their cameras on because we are a community, but feel free to switch them off if you prefer. The chat function has been turned off for this event because we're using the question and answer function for you to pose questions to our speakers. All you need to do is select the Q&A button at the top of your screens. We've got a lot of content this morning, so we will aim to allow our speakers to answer questions at the end of their sessions. However, we do have an excellent panel discussion at 11:30 this morning, so we will have an opportunity at that point for questions as well. Microsoft has advised that it's best to use a laptop or PC and not a phone, and the browser version of Teams and not the app to get the full webinar experience. Therefore, if you have any problems accessing the Q&A, please try switching to the browser version. If you're unable to access the Q&A and have a question you would still like to ask by the end of the session, please use the Contact Us form on our website. Also, should we experience any technical issues and the webinar ends earlier than expected, please wait around 30 seconds and then rejoin either by clicking the rejoin button on your screen or via the original joining link. Finally, we encourage everyone to share this event and any activities that you are running in your organisation up and down the country during Clinical Audit Awareness Week. Please share on social media using the hashtag CAAW26, and together let's shine a light on the importance of evidence-based healthcare improvement this week. I'm now delighted to hand over to Dame Celia Ingham-Clark. Dame Celia was awarded a DBE in 2025 for services to the NHS, and is a former Deputy Medical Director at NHS England. Having held senior roles in clinical governance, patient safety, medical education and population health, she understands not only the systemic challenges facing healthcare today, but also the difference that patient-centred, sustainable improvement can make. Over to you, Celia.
Thank you very much, Rachel, and welcome everybody. I'm delighted to be here today in my role as Chair at HQIP. And as I'm sure you already know, HQIP commissions the National Clinical Audit Programme on behalf of NHS England and the Welsh Government. Now, I'm a surgeon by background, and I was originally aware of clinical audit when I was a doctor in training. And I discovered the programme of national clinical audits when I became a senior medical leader for the first time as medical director at the Whittington Hospital in the 2000s. This was really helpful for me at that stage to improve the quality of care for patients in our hospital. Later, as medical director for clinical effectiveness at NHS England, I liaised with HQIP to support their commissioning of these national clinical audits, and I helped to modernise the format of the reports so they became more widely accessible with the summary infographic and a manageable number of recommendations. I also set up a representative group to look at the recommendations where they extend beyond a single specialty and where they might need national support from NHS England. For example, the Embrace maternal care report put in lots of recommendations that actually applied to all doctors, not just doctors and other healthcare professionals working in maternity. Following my retirement from NHS England 2 years ago, I was thrilled to be appointed as chair at HQIP. The suite of national clinical audits has expanded over recent years, and now it includes more that are based in primary care, so it's more extensive than it used to be. So, for example, the National Diabetes Audit covers primary care as well as secondary. So what about the value that these national clinical audits bring? Well, I think there are three things. First of all, they help the health service to learn from mistakes, for example, through the National Child Mortality Database and the Clinical Outcome Review Programme. These include a deep dive into the care provided when an adverse event has taken place. For example, in 2020, the report Saving Lives, Improving Mothers' Care highlighted the risks of sudden unexpected deaths due to epilepsy in pregnancy, and it made recommendations that have been widely implemented to reduce risks for pregnant women. Secondly, the national clinical audits enable an organisation or a commissioner to compare local care with other organisations and against specific standards. And through this, we have seen across the country reducing time for stroke patients to get their treatment, increasing access for patients with prostate cancer to the right treatment and improving their experience alongside that, and reducing mortality after bowel cancer surgery. And the third thing that the national clinical audits bring is their outlier programme. They identify to the organisation and to the commissioners where the organisation is a significant outlier on a particular metric. That's at 3 standard deviations, so it's a long way outside the average. And the example there I would give is in terms of mortality after fractured neck or femur. And it enables an organisation, if they get such a highlight, to actually look at that area very, very closely and to put measures in place to improve the situation for patients with those conditions. So the NCAPOP programme provides a solid and reliable framework for assessing the quality of care across most large specialties, and it gives clinicians, organisations and patients a focus, enabling them to drive improvements across the NHS in England and in Wales. Thank you.
Thank you so much, Celia, for that great opener. It's lovely to have you here today and for obviously for you to be the chair of our board as well. So thank you very much. I've had the absolute pleasure of working for many years with our next speaker. Professor Edward Baker, CBE, is a paediatric cardiologist and senior healthcare leader with extensive experience in quality improvement, regulation and patient safety. Ted trained at the University of Cambridge and St Thomas's Hospital Medical School and specialised in paediatric cardiology at Guy's Hospital, where he contributed to the development of cardiac MRI as a non-invasive approach to assessing congenital heart disease. He has held senior leadership roles at Guy's and St Thomas's NHS Foundation Trust, including medical director, where he led major service transformation and championed values-based leadership and patient safety. He also led the 2008 National Report on Specialised Children's Services, influencing the organisation and commissioning of care across England. Ted served as Chief Inspector of Hospitals at the Care Quality Mission for 5 years and is currently chair of the Health Services Safety Investigation Body, promoting learning-focused, system-wide approaches to improving safety and quality of care. Ted, over to you.
Thank you, Rachel, and thank you, Celia. I have to say, I'm really grateful you've invited me to speak today on a subject I think is really important. As Celia has described, clinical audit has a huge role to play in improving services. And as I will explain, I've seen the changes that has brought about. I suppose the question is, how can we make them even better? And that is the issue I'm trying to challenge today. Now, the NHS 10-year plan promised, excuse me, a new transparency on the quality of care and aims to make the NHS the most transparent in the world. As Rachel's just outlined, I've worked as a clinician, a clinical manager, a regulator, and now in national safety investigation. So I have seen the importance of transparency about data, and I very much welcome the commitments in the 10-year plan. But transparency isn't simple. It needs safe space, or psychological safety if you prefer, to work effectively to its full effect. And that is what I'm going to talk about today. Some of you may have seen the blog I wrote to accompany this talk. It argues that we need to put in place the structure and governance that builds a safety culture with real safe space if we are to fully translate the insight that transparency of data provides into the impact we want to achieve. Now, as Rachel said, I'm a paediatric cardiologist, so this is not a new issue.
Ted, you appear to have frozen. Can you still hear us?
Sorry, I lost you there a moment. Are you still there?
Yes, thank you.
Yeah, sorry about that. The slide is a quote from the BRI inquiry in 2001. And I'm a paediatric cardiologist, as Rachel said, and my eyes were open to this issue when my specialty was at the centre of a safety crisis at the time. In Bristol, the outcomes for paediatric cardiac surgery became a national issue around the turn of the century. Overall mortality rates were about 13%. The problems were known about, but no action was taken to improve. And Ian Kennedy, who led the public inquiry, made countless recommendations as a result of that inquiry that have changed our approach to clinical governance ever since. But one finding from the lengthy inquiry report struck me then and has stayed with me ever since. And it's this one on the slide. He said there wasn't a lack of data about clinical outcomes. He said the system was awash with data, but there was no transparency. He concluded that in the future, there must be openness about clinical performance. And over the last 25 years since that report, we've tried to achieve that openness, that transparency. What has it delivered and where has it fallen short of expectation is the question to ask. And that's what I want to explore today. If you look at the first part of this quotation, you'll see a hint of where the problem lies. Transparency isn't the same as honesty. We can be transparent about data, but fail to understand what it's telling us. Next slide, please. Thank you. So this is what happened in paediatric cardiac surgery after that report over the last 25 years. It's the unadjusted 30-day cardiac surgery mortality for children under 16 years in the UK. And it's truly remarkable. There has been a steady and substantial fall in mortality over those 25 years. And this is while children have had definitive surgery for complex heart problems at an ever younger age. And the cases that have been repaired have become increasingly complex and high risk. Despite that, the mortality has fallen. The overall mortality in the UK now is just over 1%, which is amongst the best in the world. Did transparency deliver this improvement? No. It was better earlier diagnosis, better surgical technique, better pre and post-operative care. But I have no doubt that transparency was important in providing the context, the insight into which all those improvements could be made. The knowledge that the outcomes were published changed behaviour, created accountability, gave clinical teams the reason to examine their own practice. So transparency can deliver. There is no doubt about that. Next slide, please. It's not just in my specialty it's delivered in many other specialties. And Celia was quoting some results of audit a few moments ago. Here are some more from HQIP's current portfolio. Cardiac surgery, which isn't on there, has improved. Adult cardiac surgery has improved, but hip fracture mortality halved, lung cancer and bowel cancer survival improving, heart failure outcomes improving. So there has been enormous benefit from transparency. Outcomes have improved, and the variability of outcomes between units has reduced. But for audit to be truly effective, it has to be a learning function, not a compliance exercise. And it wasn't the data itself that drove these improvements. It was the use of that data to inform improvement activity by clinical teams. When I moved from clinical practice, I went on to the CQC. And I was a great advocate of clinical audit within the CQC. Indeed, one of my key contributions to their work was to establish that national clinical audit participation was a prerequisite for a satisfactory regulatory assessment. Surprisingly, when I started, there was some doubt about whether it should be, but I made sure that it was. And I think that is really important. But I learned something else at the CQC. Some clinical services with satisfactory audit results still had serious problems. People sometimes assert that regulation should be entirely data-driven. I wish it were that simple. I saw many examples where whistleblowing or our inspections brought to light problems where the data had not done so. Next slide, please. So here is an example of the paradox. I'm not going to talk about individual units, but as we've seen only this week, this paradox is demonstrated at a national level with maternity services. Maternity services have had transparency for longer even than cardiac surgery, and key outcome measures such as extended perinatal mortality have improved. It fell, for instance, from 6.09 to 4.88 per 1,000 live births between 2013 and 2023, a substantial improvement in outcomes. But what is happening alongside this headline improvement? There's rising maternal morbidity, persistent inequalities of outcome, escalating negligence costs, and repeated and consistent and distressing accounts from women themselves of harm, dismissal, and trauma. Maternity exemplifies the issue, but this is not unique to maternity. Headline indicators can improve even as underlying conditions remain unsafe. Headline indicators alone cannot provide assurance about complex and cumulative systemic risk. Next slide, please. Maternity is an example of what the CQC encounters across the whole NHS. Dashboards are green, targets are met.
I'm hoping Ted will appear again in a second, so we'll just give him a second.
Hello, are you back? Sorry about that. Okay. Dixon Woods called this comfort-seeking culture. Organisations give credence to indicators that reassure and discount those that don't. CQC inspections have found this culture at scale across the NHS. This is not a measurement problem, it's a cultural problem. And in my blog this week, I stressed that we need to change culture, but we can only do that if we change the environments and governance structures first. Next slide, please. The work many of you have been involved in has created a comprehensive and technically sophisticated programme of clinical audit. And this work is enormously important. As we have seen, it undoubtedly has a major impact. But if we could achieve more, if we could close the gap between what it shows and what organisations do about it, between insight and impact. CQC, HQIP, and now I'm working at HSSIB, I can see that they each encounter this gap from a different vantage point. And I think it's important to recognise that individually those organisations can't close the gap, but together, working together, they might. Next slide, please. As I've said, this was a problem I saw when I was at CQC, and I was very pleased when HQIP and CQC together developed National Clinical Audit Benchmarking Programme, which I now see, and I think Celia referred to it, covers 24 national clinical audits. I found that on our inspections, NHS boards generally did not see clinical audit data, and sometimes they didn't even know it existed. Working with Danny Keenan, who was medical director of HQIP at the time, we developed this tool. I told my inspectors they should ask boards if they'd seen these charts, and this is an example of a chart from a national audit of the PICANET audit of paediatric critical care. I told my inspectors they should ask if boards had seen these charts and how they used them, not to focus on what the data showed, but how it was used. Was the organisation engaging honestly with what it showed? Were they gaining insight and using it to drive improvement? Next slide, please. We had endless discussion about HQIP's outlier guidance. There was a real cultural pushback about proactively sharing data with the regulator, which really worried me. I wanted both alerts, that's at 2 standard deviations, and alarms at 3 standard deviations to be proactively shared with the CQC. For the alarms, the CQC might well ask for an investigation of the cause, and everyone accepted that. That wasn't controversial. But the CQC would not do this for an alert at 2 standard deviations. They are much too common, but it might want to see how the organisation responded to the alert. Did it use it as the basis for learning for honest inquiry? The regulator, of course, has a challenge. You must do this in a way that does not undermine the safe space that allows learning to take place. And I'm not sure the regulator always gets this right, I should say. The risk is that any outlier, alert or alarm, triggers a defensive response rather than a learning response. Data is managed rather than used, and learning is suppressed. Next slide, please. In our assessments, we found that the well-led rating was the strongest predictor of safety performance, stronger than any process or compliance measure. What staff said about their working culture was more predictive still. Evidence, if you need, that psychological safety is not an optional aspiration or a cultural aspiration. It is essentially an essential precondition for learning. Audit programs themselves are not neutral. How audit is used, how transparency is managed, and how outliers are handled shape the cultures of the clinical team and organisation, the very culture that we depend upon to drive improvement. Next slide, please. I just want to sidetrack a little to discuss a word that is often used but seldom defined. We often hear calls for accountability. But what do we mean? Does it mean, as the Latin origin suggests, to count, to collect data, to submit data, to demonstrate compliance with benchmarks or targets, to provide data-driven assurance? As we have seen, this is in itself not enough. So does it mean to give an account, to honestly explain why something has happened, to promote learning? Well, I submit to you, it has to mean both. It has to mean both. It's not either or, but there has to be a balance between these 2 forms of accountability. We need an intelligent approach to accountability. Honora O'Neill, a philosopher, gave Reith lectures about accountability in public institutions in 2002. They're well worth listening to if you missed them when they came out. And she asked the question, can trusts in institutions be restored by making them more accountable? Or do complex systems of accountability eventually undermine trusts? More accountability of the accounting kind is not always better. It can create an appearance of accountability, an appearance of assurance, but undermine the understanding and trust that leads to improvement. We need a system that balances accountability . Well, I'm sorry, it keeps dropping out. Are you back again? Yeah, okay. So you might think that such a system is impossible to achieve, but such systems do exist in other industries, just not yet in healthcare. Next slide, please. So as we've seen in cardiac surgery and other specialties, transparency appears to work. Outcomes have improved. But we've learned that outcomes can improve while underlying harm persists. Maternity is the most clear example of that. And transparency can lead to disclosure without understanding. O'Neill covers this in an article she wrote for Clinical Medicine in 2004. Publishing an outcome is not the same as understanding and communicating why it is what it is. Collecting audit data is not the same as using it to learn and understand. Intelligent accountability requires organizations not just to publish data, but to engage with it and to learn from it as much as they can. Next slide, please. So, as I said at the beginning of this talk, safe space is not a nice to have. It is essential if we are to understand the real circumstances in which we provide care and how they need to change. Now, HSSIB, where I now work, operates under statutory safe space. Evidence given to our investigators is legally protected from use in disciplinary, regulatory, or legal proceedings. This is hard legal protection that can only be overturned in exceptional circumstances by the High Court, just like other high-risk industries. Why do we need it? Because fear distorts accounts. Fear leads to partial and censored accounts of what is happening. And without honest accounts of what is happening, we will not learn the right lessons and make the right improvements. When there's fear, audit can become when there's fear, accounts can become a performance rather than an honest description of events. Without honest accounts, we cannot learn. Without honest accounts, we will not have the impact we seek. There is a parallel here with what I was talking about in terms of HQIP alert and alarm outliers. Alert data needs safe space to understand. Alarm data requires intelligent accountability, as described by O'Neill. The challenge is to deliver both accountability and learning together. How can we preserve safe space and also be accountable? Next slide, please. You may think that's impossible, but other industries know how to do this. Healthcare believes it's an exception and refuses to learn from them. And one of my concerns is this sense in healthcare that we are different from other industries and cannot learn from them. We need to manage safety in a much more structured and coordinated way. If we don't, we will not create the learning culture that is needed to fully translate insight from data into impact on improvement. Healthcare is provided by a variety of complex systems working together. Safety management across them is currently neither consistent nor coordinated. It's fragmented. Accountabilities, priorities, and learning are often vague or unclear. Safety recommendations are often not implemented effectively. The structural answer has to come first. We have to create the structure that can manage safety effectively, and then we need to change the culture. If we try and change the culture without changing the structure, we inevitably will fail. And we've seen that over the last few years, where exhortations to change culture have not had the impact we anticipate. The structural answer is a coordinated safety management approach, bringing together safety policy, risk management, safety assurance, and safety promotion together system-wide in an integrated way across the healthcare system. HSSIB recommended a national initiative to develop just this kind of approach in healthcare way back in 2023, 2.5 years ago. The intention was that eventually it would become, like in other high-risk industries, a regulatory requirement. And if you talk to some of the other high-risk industries, such as aviation, they will say that when safety management was made a regulatory requirement, it completely changed the safety of performance, but also the safety culture in those industries. I discuss this more in my blog. We need to change culture, but we will not do that without the right structural elements being in place first. So after 2.5 years, we haven't made as much progress as we'd like on this, but I still think it is fundamental to turning insight into impact. Next slide, please. So that, I think, is the overarching solution to this. We need to change the way we manage safety to build the right structures and then the right culture across the health system. What can we do in the meantime? Well, we need to start off by recognizing that psychological safety and safe space are real necessities, not cultural aspirations. Safe space isn't nice to have. It is absolutely essential if we're going to be effective in driving improvement. Back again? Yeah, okay. We need to create the equivalent safe space locally, and we need to find a way of doing that. Now, people often ask about quality improvement and the relationship to safety management systems. And I published another blog a month or so ago about the relationship between quality and safety. But fundamentally, you cannot have effective management of the wider quality agenda unless you've got safety managed in the first place. So I'd start with managing safety effectively and then build quality improvement or an integrated quality management system on top of that. In terms of clinical audit, we need to focus on alert alarm, and we need to get the culture right around finding out about managing outliers. And that is for local teams, it's for HQIP, and it's also for the regulator. And I accept the regulators aren't necessarily have got their behaviour right on this at the moment. And one thing I haven't mentioned so far, but I think is really important and is very much central to HSSIB's mission, is to make sure that we involve patients and staff at every level in driving improvement activity. Recommendations are much, much better if the recipient is involved in drawing them up. And one of the things we're working on at HSSIB at the moment, again, hopefully to deliver sooner rather than later, is to bring all recommendations together into a national repository so that priorities can be set effectively and individual providers don't feel overwhelmed by the number of recommendations they receive. And one of the things that I made clear when I was working at CQC, and I still think is really important, is that the first stage, the first level of assurance you get is active participation in clinical audit and quality improvement. If a system is not auditing itself, if it's not got any attempt to improve on a day-to-day basis, then the fundamental basis assurance is not in place. Next slide, please. So this is my final slide. So just to summarize, I am convinced that the evidence that audit improves outcome is absolutely clear. Tens of thousands of lives have been saved. Pediatric cardiac is an example, but hip fracture, bowel cancer, lung cancer, heart failure, and many other services. The question is not, does audit work? The question is, why is the improvement from it still inconsistent? And why can you have headline outcomes that appear satisfactory with safety problems still present in services? The answer is to understand the importance of psychological safety, to allow honest understanding and learning. We need to manage accountability intelligently so that it does not promote defensive behaviours. Leaders must understand and must work to build the right culture to protect learning environments. But we tie their hands if we do not first create the governance structures that nourish the cultures we're trying to build. Exhortations to change culture have been many, and they have generally not worked. We need practical actions to change the way we manage safety, to build the right culture on that. Thank you very much.
Thank you so much, Ted. It's always fascinating to hear you speak. And obviously, I've worked with you for a long time now, so I'm really grateful for your insights, both from HSSIB and previously as a regulator, but also as a clinician working on the front line and obviously sharing with us what happened at your own trust as well. Have we got any questions, colleagues, in the chat for Ted?
Yes, we do. We have them flooding in. So thank you, Ted, for that. I think the first question is, it actually cuts to the heart of everything you spoke about, and also cuts to the heart of the blog that you shared, which I, by the way, put a link in the Q&A to. So if anyone's interested, do take a look at that. And so the question is really, what practical changes are needed, both from regulators and healthcare organisations, and I might add, and any others, frankly, to shift a culture from compliance to genuine learning?
Well, I think the overarching issue is to move together, for us all to move together to a much more managed way of tackling safety. So that's the big answer. But practical short term, I think the work that I did at CQC with HQIP, with Danny Keenan around the National Clinical Audit benchmarking was a great start. But there's probably a lot more we can do. And part of that is to align the regulators and HQIP's agenda around improvement. But part of that is also to, if you like, ensure that people understand what the regulator is trying to achieve and work with them to achieve it, rather than seeing the regulator as a threat. Of course, the regulator needs to change its behaviour as well on that. And that's something I'm very conscious of. But having said that, I'm really worried if people see a regulator, or perhaps other bodies such as NHS England or commissioners, to be a threat to their improvement. We need to build that really positive collaboration working together, accepting the fact that everywhere, if a clinical audit is not identifying problems, it's not doing its job. Clinical audits need to identify problems which can be improved, and everyone needs.
I wonder if we need to, colleagues, we might switch Ted's video off momentarily, and that may help with his bandwidth. I'll just hang on one moment while we hope that Ted can come back to us. Looks like we may be struggling to get Ted back to us. If he does come back to us, we'll ask a question. In the meantime, here you are,
He's
Ted.
back, Alicia.
I'm back again. Sorry, keep freezing, but I think we're working anyway. Go on, Alicia.
I think the conversations are so good that it's worth it. Again, back to the practical. Danielle has asked about how, as if you're involved in clinical governance, responsibility for management of benchmarking, monitoring, submission of national clinical audits, and so on. How do we best engage with clinical teams so that they understand that clinical audit and compliance is not just a tick box exercise, but really genuinely about learning and opportunities for improvement? Any advice?
Well, I mean, I think the initial stage is to try and provide them with that safe space, because I mean, clearly clinical teams worry if there are problems in their unit. And if you look back to the Bristol report that I started my talk with, I mean, the story is there. Any clinical team can recognise it. There are problems, but everyone's just afraid to admit them and deal with them. And so eventually, the problems become severe and they aren't properly managed. And I think, you see that, I mean, that was 25 years ago, but we still see that in some of the safety problems that are coming. And so you need to work with the clinical team to give them that safe space, so they don't feel threatened by the presence of issues that are raised by clinical audit, but feel that they're going to get support to manage them. And I think that that safe space is really important. But having said that, we need to understand that issues of accountability and holding people to account, and a lot of what we hear when there are safety problems, we talk about accountability, and accountability is seen as a threat, and we need to learn to apply accountability in an intelligent way. And as I said, as I was talking, we need to understand the tensions between accountability and learning and manage them intelligently. So I think there's a lot we can do there to improve the culture locally. But ultimately, until we manage safety much more proactively and create, if you like, a safe environment where people are not worried that they are the holder of all the risk, then this will not win this. And the great thing about managing safety effectively, it means that individual clinicians or managers don't feel that it all comes down to them. And any safety problem is a failure on their part. And so they don't see that as a threat. So creating effective safety management creates much better psychological safety for staff working in the unit. So that's why I think it's so important. It's so important because it creates that, if you like, psychological safety more effectively. And as I was saying in my talk, other industries have done this. Other industries have done this. They know how to do it. We need to learn how to do it.
As I was listening to you, I was thinking about this, how we move from this culture of what I'll call fear, I think you use the word fear too, through to a place where we can share genuine learning. And there's not this expectation that things go right 100% of the time, but instead we use them as opportunities for learning. And I was thinking about the aviation safety sector and wondering, in practice, I mean, do we do something very large scale, like have the leaders within healthcare go talk to these other industries, start to learn from them about the mechanisms they've put in place?
Well, I think those who haven't should, because it is inspirational going to talk to these other industries and seeing how safety is the center of everything they do. And they will talk about safety, not just as being to prevent harm, it's to make their industries better to work in, better experience for the people they're providing services for. They make them more productive. They improve their financial control. I mean, managing safety has benefits across the board, but healthcare just won't accept that. There's a kind of cultural resistance to accepting that. And you often hear people saying, oh, we're not like aviation. Of course, we're not like aviation. We're more complex, and the whole point is the complexity itself demands much more systematic management of safety.
And notwithstanding the fact that I may be adding to what you call the exaltation problem in your blog, that's on HQIP's website, by the way, it would be suggesting that perhaps the two sectors could get together. There is a call for change and that you do try to learn from each other in terms of culture change. But of course, I wouldn't want that to stop at the exaltation of that.
There hasn't been a public inquiry into an aviation problem since 1976, I think, 50 years. How many public inquiries into healthcare have there been in that time? You know?
Yes, it's quite telling, isn't it? A very quick thing. On your slide, turning insight into impact, you use an abbreviation SMS. I'm sure you're not talking about text messaging. Someone would like you to explain.
Oh, SMS is very old-fashioned text messaging. A safety management system, sorry. If that's not self-evident, apologies.
No, I think it's just good for us to be explicit about that. Something else that's come up, and again, if we're just going to be transparent and explicit, you did say transparency is a good thing, there's a sort of a mild concern, not necessarily quite a criticism, that NCAAW, the National Clinical Audit benchmarking site that HQIP and CQC run together, is that the data is somewhat lags behind the reports. I think we both recognise that, don't we? And we've seen great improvements of late. Any thoughts on that in the future?
Well, I do think that is an issue, and I'm not quite sure how HQIP and the National Clinical Audits are dealing with it. But I think if there's a big lag of the data, and it was often 2 years or so when we're working with CQC, then that does disconnect looking at the data from the changes. And of course, it allows people to say, oh, well, that was 2 years ago, we're much better now. And of course, in 2 years' time, you found out you weren't much better now, but you didn't know. So I do think making the data more timely is well worth it. Having said that, just think about what I was saying about National Clinical Outcomes benchmarking. It isn't the data as much, it is the willingness to interact with the data. And I had this real worry. I went round NHS hospitals and I asked board members, tell me about your experience of National Clinical Audit and how that's changed. And it's amazing how many board members had never even heard of National Clinical Audit, let alone not seen it. It was something that was protected by the clinicians. The clinicians in their hospital were working on it. They were contributing to it. but this was not kind of diffused throughout the organisation. And one of the reasons for producing those forms was to actually get boards to look at them and produce them in a format that boards could assimilate, because obviously, you know, the complexities of a national clinical audit programme is beyond the time or competence of the board to look at. But some simple charts that showed how the organisation benchmark were very, very valuable. So in a sense, it was trying to change behaviour as much as to prove that. And, you know, and I think if anyone who's on the call today, you know, is thinking about using it, use it to change behaviour. Use it, make sure that the board is seeing it. The board should be seeing this data on a routine basis. And, you know, and if they're saying, well, this is 2 years old, can I see something more up to date? Good for them.
Yeah, that would be a good thing, wouldn't it? I have shared a link to the NCAB benchmarking site on the Q&A, so please do take a look, but also note that things are improving, but we do admit slowly, and we are working on improving more in the future. Before I hand back, one very quick question is around, at any point, could you share a link to the Bristol inquiry? You can probably tell from my accent that I have to own up that I'm from Bristol, that people have been asking for information about it, if you could share it.
It is actually a great read. It's very long. And of course, a lot of it is specific to paediatric cardiac surgery in Bristol, but that's not the point. It's the general points that it makes about clinical governance and transparency and the use of data, which are still relevant today. And just going back and looking at it, you think, oh, this is, you know, we've come a long way in 25 years, but still a lot of the themes around transparency, around using data effectively to learn and improve, and not being scared of the data, and accountability. And actually, Kennedy was very modern in his approach to accountability in that report. Which, you know, I think is a great reflection on him at the time. But having said that, you know, we've moved into, we haven't really changed the culture. And as I say in the blog, and as I said at the talk, I think the reason we haven't changed the culture is not because we haven't tried and we're not committed and we don't understand the need to change culture. It is because we still have not created the environment in which the right culture can be nourished and grow. We expect people working in an environment that creates a defensive culture just to change their culture by force of will. It won't happen. We need to create an environment that takes away that need for defensiveness and gives people, that liberates people to actually operate true to their values, which is, I think, what we want.
Okay, that's grand. We've got lots and lots of questions flooding in. I will hand back and hopefully we'll get a chance to ask Ted some more questions at the end. Thank you.
Thank you, Lacey, and thank you, Ted. And also, just to sort of reiterate, we're talking about NCAB, is that CQC and HQIP have been big advocates for a long time, and we're seeing a lot more rollout of our more real-time dashboards, which we're really hoping to encourage trust, and especially medical directors, chief executives and leadership in the NHS to really use and look at their data in a more real time. And some of our audits actually have mortality data, quarterly mortality data in their dashboard. So things are slowly improving, but the wheels of the NHS turn very slowly, Ted, as you know full well. So our next speaker is a clinician who's been working closely with me for the last year on the inception and delivery of our new National Robotics Registry. Mr. John McGrath is a consultant neurologist in North Bristol NHS Trust, and he's closely associated with the development and use of robotic-assisted procedures within the NHS. He has played an important role in expanding access to advanced surgical technologies and chairs the NHS England Robotic Surgery Steering Committee. Working with HQIP, he has overseen the specification design for the new National Registry of Robotically Assisted Surgery, as we now call it NRAS. John, I'm delighted to hand over to you.
Rachel, thank you, and thank you for the invite. I'm delighted to participate in the Clinical Audit Awareness Week, and very grateful for the invite. I'm going to talk about scaling up of robotic surgery in the NHS, which you may have seen, it's grabbed some of the headlines in the last 12 months, because as a health service, we have committed to scaling up to 500,000 of these operations a year by 2035. And moving most standard keyhole or laparoscopic surgery onto robotic platforms. And the bit I really want to take us through is how the registry will help inform this. Those of you who know about robotic surgery, I'll expand on it in a moment. It's scaling ahead of the evidence. which I'm afraid is not uncommon in surgery where new technology gets adopted, but the full evidence isn't yet available, and it's scaling in an inequitable way. So we've got areas of the country where there's high coverage and areas where there isn't. And to Ted's point, really, to build on that, how do we not just collect data, but how do we collect data and engage with the data and use it to improve clinical care and use it to address issues such as inequitable access or safety and evaluation as the data comes along. Next slide, please. Thanks very much. So what's happening with robotic surgery? We've seen a 13-fold increase in the last 10 years. We currently do around 40 to 50,000 robotic operations a year. And the ambition is to get to 500,000, so a 10-fold increase by 2035. When we last did a baseline assessment, there was about 140 robotic platforms in the NHS. But in fact, in the last quarter, 34 robots were bought by the NHS, and these cost anywhere between 1.5 to 2.5 million, and they're now across a dozen or more procedures. And historically, I'm a urologist by background. Historically, 80% of that work was in urology. It was radical prostate surgery for prostate cancer. And now that's less than 40%. So gynae, colorectal, trauma and orthopedics, cardiothoracics, children's, spines, robotic assisted surgery is really permeating through most of what we do. But there's a wide and unwarranted variation, which I think is where one of the key ways in which the registry will come in. Next slide, please. What is robotically assisted surgery? Why are we adopting it? Well, this is where the surgeon is actually separate from the patient. They're sat at a console. They get 3D vision and there are robotic arms that are docked in a conventional keyhole way inside the patient, and we get much better dexterity. It's ergonomically more comfortable. We can do things that are difficult with conventional keyhole surgery. And an important aspect is that we can get more surgeons fully confident and up to speed with minimal access with keyhole surgery if you put robotic assistance in there as well. For patients, importantly, it's a shorter length of stay and faster recovery, and less pain and faster return to productivity or to leisure activities. Now, for the NHS, some of the benefits we hope to realise is reduced bed days, so more day care surgery, a short stay, less high dependency care because people are having less open conventional surgery. And interestingly, we've got a recruitment crisis. Residents coming off the top of the training schemes want to work in hospitals that have access to robotic surgery. And it's the converse, it's a problem, is they do not want to work in hospitals that don't. And traditionally, the robots were mainly in large teaching centres, often in large urbanised areas. And so we know that some of that inequity is actually rural and coastal and geographical as much as anything. And I will mention then, where does the registry play into the UK PLC, our ambitions to be a life sciences leader, our ambitions to be welcoming to new med tech. How would the registry support us with that? Next slide, please. This is the growth over the last 10 years. We've touched on already, and it's going exponentially now. We're set to say, I think, over 100,000 procedures next year, scaling up with the increasing adoption in different specialties and the purchasing of new robots as well. And imminently, or in fact, currently, lots of new robots appearing on the scene. Costs are coming down and the choices are getting greater for individual trusts or for regions to purchase these. If we could go to the next slide, please. But this is the problem. This is the problem if you're a patient. Each dot is an ICB in the region of England, and this is the utilisation of robotics per 100,000. What you'll see is this is a classic scattergram. So we've got areas of the country that have no robotic access. We've got other areas, mainly in the southeast and around London. We've got 90 per 100,000 patients getting robotic surgery, and we've got everything in between. So we have a huge inequity of provision and hence a huge inequity of access. And also downstream, that plays into challenges with training. If there's no robotics in the region in which you train, you will not be exposed to it and not be delivering robotic surgery. Next slide, thanks. So last year, July 2025, we published a guide for safe implementation of robotics. And this was really because we'd been asked by Stephen Powis. He'd noted that about 30 robots had gone in year end. What was our planning? What was the supporting information? What was the direction of travel? And we produced this guide, which wasn't strategic, but it looked at how we configure robotic programs. We said something about procurement, training, safe implementation, but importantly, we stated that we needed a mechanism for evaluation and registration of robotic procedures within the NHS, and that in turn could feed into the research environment. And so we had a robotics steering committee that you can see had broad representation from NHS England, NICE, Department of Health, Department of Science and Innovation, the Royal Colleges and training structures as well. Next slide, please. What was somewhat unexpected was the same month the NHS 10-year health plan was released, and robotic surgery was picked out as one of the 5 big bets. And if truth be told, we weren't fully expecting that. We welcomed it, but it was placed front and forward with that commitment underpinned now to say we would go to 500,000 procedures, but it also says in the smaller box near the bottom that we would commit to a national registry, and we would collect the data and we'd have that operational by 2029. And I hope to be able to show you that we should be operational ahead of time. And why was that important? Maybe too small to read, but the big bets essentially to try and transform healthcare, the NHS, to maximise its potential and become a global leader in the adoption of health technology and excellence in care as well. Next slide. These are the 5 big bets, just as a reminder: data, AI, genomic medicine, wearables, and robotic surgery. And just as a point, I would indicate, I think that robotics is actually across some of these other domains as well. There's data in there, there's going to be AI alongside the robots and wearable devices, hospital at home, monitoring recovery remotely. So I think it cross-cuts into other themes. So where does the registry fit? I've stated here that I think it operationalizes the robotic big bet. It's going to give us the outcome evidence we need to scale safely, so we can do safety monitoring to demonstrate value, and also to know where the robots are and where the procedures are happening. So can we use registry and data to inform provision of services and to ensure that those are equitable and those are being performed safely, and we're collecting evidence as we go. Next slide, please. And that's really how it nestles into our earlier guidance around the configuration procurement training. It's going to help us meet the evaluation requirements that we set out, and that commitment within the national guide to say that we would engage in evaluation and registration, and that would underpin our future activities over the lifetime of the 10-year plan. Next slide. So how did the registry come about? It really came off the back of NICE. NICE decided they would use the early value assessment methodology for robotics. If you're not familiar with that, it's a newer methodology whereby if the technology is gaining traction in the NHS and it's ahead of the evidence, rather than waiting for the evidence, it's declared safe at that time. It's conditional, not permanent approval, and it's stated that evidence generation is required, and there's a time frame on that. So for robotics, that was May 25 to May 2028. Companies were required to register with NICE and register an evidence generation plan. And then during that time, the cost effectiveness, clinical effectiveness, etc., would be understood. And at the end of that period, then recommendations would be made around individual robotic platforms. And those were in soft tissue, mainly cancer surgery, and orthopedics, so joint replacement as well. Now, our feeling was if you needed that evidence generation across the NHS, it was a good construct to say, let's have an infrastructure for doing that, or at least supporting it. And so a national registry, as we're discussing today, through HQIP, gave us the opportunity to use routinely collected data to gather information on every robotic operation performed in the NHS, and out the back of that to then collect both efficiency, productivity, and clinical measures, so that the length of stay, readmission rates, other metrics that we might want to build into that, and in time enriching that data set so that it becomes even more granular in terms of the outcomes and the benefits of robotic surgery. Next slide, please. The read across the NHS 10-year cancer plan came out later that year in the autumn, at the end of last year, and again robotics was highlighted as one of the prominent areas that we would focus on within the cancer plan, really to try and deliver excellence in cancer care. And robotic surgery is still predominantly in cancer surgery, though increasingly in benign surgery as well. And again, signposting to the outcomes evidence. So how we were going to evaluate this, complications, longer term outcomes, is this value for money for patients for the NHS? Is it as effective as it can be? Is it optimized? Next slide, thanks. Just before I talk about the registry and what we are procuring, I just wanted to set the wider context. Robotic surgery and its adoption in the NHS and the National Registry really strengthens our intent to be part of the life sciences opportunity. If we can create a system where the robotic technology can be adopted, where manufacturers can plug into a National Registry data set, where they can provide evidence on safety and outcomes, then we have a good landing site for robotic technology and other technologies that will improve healthcare. And in doing that, our work really extends, and our working committee extends into the various government offices of life sciences, science and innovation, medtech, and across into training, into NICE, into the colleges. So it's a really broad ranging piece of work with the registry really at the heart of that. Next slide, thank you. Let's go, we'll skip that one. I think we've covered it. Next slide, thank you. So this is the registry that we went out to tender back in March. It came with funding from NHS England. The delivery would be through HQIP, the specification design we worked through collectively, myself and the team at HQIP, and we secured 1.3 million in funding for a 3-year initial setup of the audit. They're conventionally 5-year funding, but with 3, and I'll talk about what happens in years 4 and 5. Next slide, please. So the contracting authority was through HQIP. We've talked about the funding that goes behind that, and the timeline I'll talk to you about in a little bit more detail at the moment, but essentially it will go live in terms of the contract on the 1st of August, and we'd expect it to be fully operational much sooner than 2029, but the contract would end at 2029, and I'll try and put some sort of prediction on when I think we'll first see data flowing through it. Next slide, please. So why a registry? This really feeds back into some of the topics we've already discussed this morning. So patient safety. These robots have been deployed for 10 years with no national mechanism for looking at who is doing what and which systems and which trusts for what procedures. And the registry will bring that all together, and we'll be able to see where the activity is happening. We want to and are aligning ourselves with the metrics that NICE have highlighted in the early value assessment evidence generation requirements. And we've got a chance for standardization. We know that unwarranted variation in care is often associated with unsafe care. And so trying to, again, understand where these robots are they being used effectively, efficiently? Do we have areas of the country where patients are just not accessing them? Are there any signals that we've got a problem in one system compared to others? And so it'll build through into that evidence base, which will help us with our guidelines, with commissioning and regulation. And we hope this will be live data. By live, we typically mean quarterly. So quarterly data and reporting in terms of both the activity and the outcomes as well. Next slide, thanks. And these are the delivery requirements. So we want the registry fully operational and live in 2029. And we are looking at the moment towards a self-sustaining funding model. And that's similar to the National Joint Registry, where a manufacturer would pay a one-off joining fee, and then there'd be a cost per procedure to have an income stream. And then we would make sure that we're using routinely collected data in the NHS. We're very mindful not to increase the data burden on organisations or clinicians or clinical teams. And so we want to really focus on routinely collected data. And this will be iterative. And over time, we hope to pull in more than simply HAIRS or registry data. We hope to pull other metrics into that as well. One of the things we've underwritten from the outset, learning from other registries, is that it must, in its lifetime, always report back into HQIP and NHS England. We must be able to see the data. We must be able to support any reshaping, redesign of the registry as well. And the registry should be portable on expiry of the contract so that we can continue to run that registry where needed. Next slide, please. These are our timelines. 4th of March, we published a notice. Inquiry deadlines closed at the end of March. We had a submission deadline in the middle of April. And I'm pleased to say we got 7 bids, which are now 6 in terms of eligibility, all strong bids. and we're in the process between now and the end of the month of scoring those. And we will then have an award decision committee on the 7th of August, where there'll be broad representation from HQIP, from NHS England senior leadership team, and we will award a contract that will start in October of this year. And that will be awarded, as I mentioned, until the end of year 3. Next slide, please. These are the award criteria. I'm not going to go through them in turn, but these are the weightings that we put on the bid and the tender and asked applicants to score against and to give us their insight. So these are the domains that we're working through to try and then come up with a ranking and hopefully then an award decision in August. Next slide, please. If you've seen the registry and you've seen the specification design, there is a section called aspirational intent. So this is the section that's not currently funded, but we've indicated areas that we might like to go to if further funding was available. And that can be things like bringing in the devolved nations, it could be adding in proms and prems. It could be talking to Finn and bringing in privately funded care as well as NHS care. So we've made it clear what those sort of aspirational intents would be as well, but these are not in the core funding and are reliant on additional funding being identified. Next slide, thanks. But we do believe that the registry will support 10-year plan, and particularly in that analog to digital, one of the 3 large domains, by digital capture of data and analyses and looking at outcomes and activity, looking at the outcome-based measures as well. And as I mentioned, AI is certainly going to be part of robotics in the very near future. Next slide, thanks. So in summary, robotic surgery is scaling rapidly. It's the fastest growing technology for us across surgery. It's in nearly every specialty and is scaling worldwide. And with that, the NHS 10-year plan is timely in picking out robotics as one of its 5 big bets. Now, through this national registry, we will understand every robotic procedure performed in the NHS. We'll be looking at patient level, we'll be looking at disease level, the types of procedures that are being done, we'll be looking at platform and device level. So is it being used efficiently? What's the downtime? And we'll be looking then at regional access and any inequities. We know, for example, that there is inequity in women's health. This has predominantly been a technology deployed in male health. And so we've got a gender inequality that we want to address. And then we've got socioeconomic and we've got geographical inequalities. And without a registry, we can't understand those. And also we can't track our recovery and our addressing of those inequities as well. It's an opportunity then to feed into the evidence base, to work with NICE. And it really is attracting a lot of international attention that a unified health service would have a national approach to the adoption of a transformational technology that we'd be putting in place, the ability to collect data and to monitor it and evaluate it. That's attractive to manufacturers, but it's also in the sights of other healthcare systems who are thinking, could they do something similar? We've got some interest in whether the registry could also be deployed internationally as well. Are there other countries that would want to use the infrastructure that we build? So I think a really exciting time to do this. It underpins the life sciences opportunity, but importantly for patients, I think if you look back on the slide I showed you about the ICBs, the variation, if we can now understand where robotic surgery is and where it isn't, what the plans are by various regions, how we signal and how we direct regions, trusts, alliances to level up and make sure we've got robotic surgery where it needs to be, and then how we produce what I believe will be world-class data in terms of the robotic activity and the robotic outcomes for patients and for healthcare systems. So thank you very much for listening. I'll hand back to Rachel. Thank you, Rachel.
Thank you so much, John. Thank you very much for joining us today. I've really loved working with you on the specification and the development of this registry. It's really exciting and very innovative, and as you say, will hopefully be world class. And your experience in robotic surgery spans for quite a while now, so we're really delighted that you're the National Clinical Director from NHS England. You come with a wealth of experience and knowledge. Celia, any questions in the chat for John, please?
I think the question should be, are there any not questions in the chat? There are so many flying in, John. I'll do my best. We've got 5 minutes, but actually we can hopefully ask you some questions at the end as well. The first question, I think, is around how the registry might fit with other similar programs, I'll call it, but national clinical audits and others that are already collecting data on their specific clinical disciplines, if you like. Any integration?
Yeah, that's a really good question. Thank you, Lacey, because one of the first things we're doing is a baseline assessment of existing registries and data sets and audits, because we know that some of those are national, such as the National Joint Registry. We wouldn't want to replicate that, and we've met with the National Joint Registry. Some of them are specialty specific. The Hernia Society, for example, have a registry. So we want to look at where data are already collected routinely. We want to see whether those should be integrated, or indeed could we lift that data burden off smaller organisations or specialty associations? Would it be helpful just to bring this all into one place? So there'll be two aspects leading up to this. One is the stock take of what currently exists and how do we prevent duplication. And secondly, an audit of where the systems and the activity is. I just mentioned we're working with NETIS, who are the National Electronic Tracking and Inventory team, who track the capital assets in the NHS, and they've had a specific project on robotics, and they were collecting data on the systems but not the activity. So that would be two examples really, with NETIS and the National Joint Registry, that we're making sure that we are linking into structure that are relevant or already exist to meet some of our requirements.
Okay, great. Thank you so much. The next question comes from our very own Tina Strack, who, if anyone was around yesterday, saw Tina. She ran our patient safety events yesterday. So it won't surprise you when I say that her question is around how might the registry identify and respond to safety signals in a rapidly evolving field like robotics, where techniques and technologies are constantly changing. But I think primarily, how will we get those safety signals out to the service as quickly as possible?
Yeah, thank you, Tina. It will be like other national registries. We're going to have an outlier process. So if we see a signal that something is outlying, then we will firstly identify it and then pass that through to the relevant organisation. Now, the normal next sense check in audits we've run before would be through to the medical director and down to the relevant management team to check the data. If we look at, for example, the British Association of Urologists, we had national registries of complex cancer. The vast majority of the time we had data problems rather than clinical problems, and the coding wasn't right or the data submission wasn't right. But then at other times there are examples where we identified problems with a clinical service or indeed with individuals. So we'll manage that through the outlier process. It's one of the things, Tina, in terms of the actual detail, how will we do it, who will do it? That's all going to be part of the early design and operationalizing the register as well. But just to signal back to you, that's absolutely on our radar, and it's going to have to be part of this registry output and the monitoring as well.
Okay, great. And don't forget, Ted is listening, so he's going to be very interested that happens.
Absolutely.
Some questions came in around proms and prems and outcome measures. I know you subsequently covered that by it being in your aspirational intent for the registry. But there is quite an interesting add-on question that is, someone says that they're embarking on measuring a recently introduced spinal robotic surgery, but would just be interested to understand from you what sorts of outcome measures might be good to use.
Yes, so this will be iterative later, largely constrained by the funding to begin with. So the funding is relatively modest for a national registry, but I think the output at the end of that, if we can understand which patients are having which types of surgery and which organisation, what our geographical and our gender and our socioeconomic distribution looks like, and then basic outcome data. By that I mean length of stay, readmissions, mortalities, the sorts of basic metrics we can get to. Now that in the first 3 years, sorry, might sound quite basic to listeners, but we don't have that currently. And just knowing where the activity is and those basic safety measures will be important. Now that's what we would think of as the spine of the core funding. And then what we want to do is to seek funding either through an industry or revenue model, or do we fund that separately? That's another possibility. And then we start to layer on much better clinical outcomes. Now, the outcomes that we collect will be defined by the clinical experts, the subject matter experts in that field. So the National Joint Registry have already identified their outcomes and in fact have prems and proms. I think one of the areas we'll be going to first is women's health. And again, we'd need to define what would be the outcomes that would be important to women. So not just the subject matter experts, but patient and public. What are those important outcomes that we could collect if funding is available to do so? Prems and proms are more challenging. Proms are procedure specific and take some design in themselves to be valid. But shouldn't we be aspiring to have those go out through the NHS app? If you've had a procedure, we know what you've had done. We're used to getting these things from other aspects of our life where we give feedback. Shouldn't we be doing that in terms of our healthcare as well? And that's certainly where I'd like to see it go. We're not currently funded for that, but that's part of our aspirational intent.
Okay, great, thank you. One final question as part of this short Q&A before the main session at the end. Will the registry measure and compare surgical error rates or even surgical data between robotic and non-robotic surgery? Will comparisons be made?
Yeah, so not ongoing later. So we've been asked about this before. What are we going to do about open and laparoscopic and the data coming across? Are we just going to look at robotics? Now, what we do want to do is a snapshot as part of that stock take, see what's happening open, laparoscopic and robotic at the moment. But the registry itself is actually going to be focused on the outcomes from robotically assisted surgery. We'll have to define an existing standard, and that's why we'll have to look at what are the outcomes currently and what's happening if you have that surgery performed with open, conventional laparoscopic or robotic. So that will be our methodology as a baseline standard, and then it's ongoing surveillance. We hope we drive up standards, we'll improve outcomes and we'll improve patient care, but that will be our comparator.
Okay, great. Thank you, John. And rather like a news anchor, I'm going to say back to you, Rachel.
Thank you very much indeed, Lacey, and thank you again, John. Insightful, brilliant, thank you. Personally, and I think at HQIP, we always like to place importance and recognise our patients and our carers throughout all of the work that they do, because they really allow us to see the work we all do through a very different lens. Kate Cullen is a parent of a child diagnosed with type 1 diabetes at age 8 years old and who is now a young adult. She's been involved with Children and Young People's Diabetes Network as a parent representative in the East Midlands and nationally as the co-chair of Families with Diabetes National Network. Kate is also a parent rep for the National Paediatric Diabetes Audit. She has also volunteered as part of the peer review programme for paediatric diabetes teams in England and Wales, and more recently she's been involved with other parent reps in the Children and Young People's Diabetic Network in a project known as the Bridges Project, to investigate how to provide peer support to other parents and carers after a child or young person's diagnosis. Kate, I'm delighted to hand over to you.
Hi, thank you. So yes, this is going to be a very paediatric diabetes focus to things, because that's what I know about. So the first slide, please. So my son was diagnosed out of the blue, 8 years old, no family history. So we had a crash course in type 1 diabetes at hospital. Fortunately, our GP sent us very quickly to hospital. So we had a very, I guess, smooth introduction to it, but it was still a very steep learning curve. Sent home to continue with insulin injections, finger pricking, checking blood glucose levels, counting carbohydrates for everything he ate. We had a great paediatric diabetes team, but it was still a really stressful time. It was, yeah, but my husband and I are both vets, so we have some sort of medical understanding, but even with that, it felt like, although we were following the instructions for diabetes, diabetes never did what we expected it to. Next slide, please. So next slide. Yeah. So we soon moved on to an insulin pump. We'd expressed an interest in it, and our diabetes team were very supportive. This was in relatively early days. And we also self-funded a continuous glucose monitor. So this is a thing, a sensor in the skin that measures the glucose levels continuously. That was something that there was no funding for at that stage. So we were fortunate enough to be able to fund that ourselves. Now, as a young adult, really. He has a hybrid closed loop system, which is an insulin pump that is connected to his continuous glucose monitor and an algorithm that measures the glucose and then talks to the pump. So it takes a lot of the day-to-day management out of doing stuff for diabetes. So throughout, our team were really supportive in accessing the newer technologies, but funding was always an issue. Next slide, please. We chatted on various peer support forums at that stage, this is 15 years ago, and found that not all diabetes care was equal. It really depended which hospital you attended and who the clinicians were and what they felt was the way to treat. We had the pump and we were self-funding the CGM, but others were struggling to access. Some parents even travelled, well, hours to go to other hospitals where they could get the better, newer technologies or just what they felt was better care. Since then, there's been huge improvements in care and access to technology, and that I feel has largely been work done by the Children and Young People's Diabetes Network, which is a network of all the clinicians treating in paediatric diabetes, helped by the NPDA information. Dr. Fiona Campbell has been a fantastic leader, and she has pushed forward a lot of the work that's gone on. Partha Carr, he was the national lead for diabetes. He's also pushed forward to increase access to technology, and I think he always said, if my daughter was diagnosed with diabetes, this is what I would want. So we need to work on improving this access. Next slide, please. So the question I was asked was, what matters most to parents when we talk about improvement? And really, parents just want to know that they're getting good diabetes care from their team. They want continuity and they want to build up relationships with their team. They want to know that they've got regular appointments and they're getting all the recommended health checks. And definitely they want access to the newer diabetes technology, and not only just access, but they need support in how to use that. So that's the continuous glucose monitors, pumps and CGM again in the closed loop technology. Another huge one is psychology support, and that's not just psychology for somebody when they have a mental health crisis. This is holistic support to help them learn to live with what is a really annoying condition. Also transition care. Really important that care is tailored to older teenage and young adult groups, so that they don't just drop off a cliff edge when it comes to moving on to the next stage. Diabetes care and support in school is another huge one, because again, there's a lot of variability in care. And as always, DK8 diagnosis. We were very lucky that we had a very speedy diagnosis, a very smooth treatment. Many parents have a very traumatic introduction to diabetes when their children are diagnosed with DKA, and that can cause all sorts of problems later on. Next slide, please. So I've just picked out some of the more notable improvements and some examples on the next slides. But improvement in practice, improving HbA1c, which is the measure of average blood glucose. But there is a lot of variation, and I'll show a slide with that. Technology access is improving massively over this last couple of years, especially. And inequalities, definitely improving, but still work to be done. Next slide. So this is from the NPDA, improvements in median HbA1c from 2010-11 up to the latest audit. And we can see massive jump down, a few plateaus along the way, but overall really improving. It's improving, but I think we're still behind some of the European countries, so still always work to be done. Next slide. But this is when we come to the variation. I was interested to hear Ted talk about outliers. So here's the mean HbA1c of all the different paediatric diabetes units in England and Wales. And this has all improved, but when we look at the individual units, there are positive outliers, but also quite a few negative outliers. And my worry is, how do we get those to change? That's still an issue, I believe. Next slide. Again, health check completions. So these are the basic health checks that all children with diabetes should get done every year at their annual health checks. Each line on this is a paediatric unit, and we can see there's still variation within that. Next slide. Coming on to the access to diabetes technology, this is recently comparing 23-24 to 22-23. We've now got 55% using an insulin pump compared to 45%, 36% on hybrid closed loop, and that is compared to 15%. And it is relatively new technology, but the increase has been nothing less than astounding, really, I would say, and is continuing to improve. And again, CGM, 79% of children and young people using a CGM. And the importantly thing with that, use of a CGM or a hybrid closed loop was associated with lower HbA1c, and that's what we're all striving to get to, better treatment. Next slide, please. So the mean HbA1c, looking at ethnic groups and deprivation groups. So again, we've got an improvement in all of these, and there has been quite a focus on the differences in the different groups. It's overall improving, but that gap still isn't narrowing enough, really. So I do believe there's still a lot of work to be done there. Next slide. So use of CGM. So this just shows over the last 5 years the increase in the use of the continuous glucose monitors. And basically, I think the data has shown the benefits of using a CGM, and the most recent sort of increase is because it follows the NICE recommendation that all children and young people should be offered a CGM. Back when we were first diagnosed and we first used a CGM, we learned about it, sort of investigating, researching. It was a no-brainer, really, to use it, because it meant we didn't have to get up in the night all the time to check blood glucose, didn't have to do finger pricks 12 plus a day. But at the time, although our team were very supportive, there was no evidence to say that it did actually improve outcomes. So there was no funding to follow. So this has been a massive change across the whole of diabetes care, and clinicians now really believe in it as well. Next slide, please. So another question I was asked were, how do data and audit findings feel from the patient side? So as a parent rep involved in the diabetes networks and the audit, it's been great to see improvements and to see improvements in equity of care. I just really like looking at the data, so I'm probably a bit of an oddity, really. But in the wider parent group, do they see the audit findings? I'm not so sure they do. It is available and there's great public access, but how do we get it out to people to see? Occasionally, when we've had parents come to us because they've felt they're not getting good care, I've sort of pointed them to the audit so they can look and see what their hospital's results are, but that's a very small percentage of people. Most parents just want to know they're getting good care and access to what everybody else has got. Next slide. So how do we ensure QI programs and the insight genuinely leads to impact? I really believe that a lot of it is down to leadership, good leaders that understand what life is like with diabetes as a family, and then they run with that and support those families. And it's also the diabetes teams on the ground. So Paediatric Diabetes has a great network where they have quarterly meetings with all the members of the team come in the area. So in the East Midlands, we have a quarterly meeting and they discuss everything and they always review and use data. I think it's really important. It's not just a tick box of processing the data because they have to. And certainly in the network, I've seen great examples of QI projects to focus on specific things and to improve. It's been a real challenge for some of them since the introduction of hybrid closed loop pumps. But some of the teams have done amazing work because they have seen the benefits, and there was obviously a huge number of people to start to implement those treatment with that. And some of the teams have just really taken it and run with it. I think the other thing is all this data, presenting the data to funders to show the benefits is a massive, massive thing. So outliers, I am really interested to hear what work can be done to improve that. I've never quite understood the process when I've heard about it. I completely agree that it has to be a supportive thing and there needs to be insight as to why they're outliers and what can be done to help those. DKA diagnosis, again, I think that's something that the data is only just becoming clear because I think there were issues in trying to access all the data over the years. Again, still too many, 26% of children and young people diagnosed in DKA. And sadly, there are some deaths still from DKA diagnosis. Next slide, please. I'm nearly there. So, how can data empower rather than overwhelm? It's all about asking the right questions. I say definitely the CGM, as I mentioned before, it was common sense to us to use, but because there was no evidence, there was no funding. Now we have data to show what we knew all along, and now there is much more access. Inequalities, focusing on that difference in outcomes related to deprivation and ethnicities, it's definitely improving, but still work to do. There's just a slide here that shows some of this. Next slide. So this slide just shows the benefit of the newer technologies. I think there's a lot of data packed into this slide, but really interesting to see HbA1c with just injections working all the way up to hybrid closed loop systems. So without that data, we would probably never know how beneficial it is. Next slide. So how national audits can better reflect lived experience. I think the audit is great, the yearly audit is great, but also there is a limit to what is asked on the data set. So asking some different questions is really useful. Not everything is measurable, e.g. quality of life, sleep. So the PREMS that runs, the most recent one was more targeted, and it was based on first year of care. And I'm going to show a slide in a second that shows some of the answers there. There's also the current PREMS is about care of diabetes in schools, which again is a huge issue, and I think there should be some really interesting information. My only caution about PREMS is, how do you get a really high response rate? I think the first year of care was better because teams were able to focus on those particular patients. Sometimes I felt there are certain people answering the PREMS and it's not actually giving us a full story. Another, just to mention, as the parent reps, we have often in the past done sort of just normal surveys, and I think sometimes that kind of thing provides real insight because we get comments from families which we can then feed back to the clinicians. But how do we get more parent care and patient voice? How do we get a better response rate to these things? Next slide. So just quickly, this was from the PREM first year of care, focusing on employment and sleep. A couple of questions were put in, whether the diagnosis of type 1 diabetes had affected employment and sleep. So 11% reported that they or their partner had left their employment due to their child's care needs, and 30% reduced their hours. And a massive 47% have their sleep disrupted over 3 times a week due to the having to get up and basically treat the diabetes. So these are all really important things to know for clinicians to know. This is what life is like with a diagnosis of diabetes. Next slide. I won't focus too much on that one. What does good co-production really look like? I think this is a huge challenge. I think as a parent rep and the other parent reps, we're all conscious we can only really represent our own experience of diabetes care. How do we reach out to different groups, different ethnicities? We need to involve more people, more socioeconomic groups, children and young people too, because actually they're the ones that are living it. Mums and dads too. Often it's mums that get involved, but dads also have a say in it. So how do we get more engagement of different groups? Next slide, last slide even. So thank you for listening. I hope it's been useful and stimulates some thought on how to meet the challenges, and also reflects how audit and the leadership in diabetes care has really improved paediatric diabetes care. So this is my son having done his London to Paris cycle ride for JDRF, and I just think it's really important that the clinicians know the story behind the patients, really. Thank you.
Thank you so much, Kate. That's really fascinating. And obviously I work with you with the National Paediatric Diabetes Audit, and you're a fantastic patient and parent advocate for that group. And it's so important that we do see the journey through your eyes. The data's great, but it's the impact it has on our patients that's the most important thing that we visualise. So thank you so much for joining us. We haven't got time for questions for Kate at the moment, but we are now opening up our panel discussion. So if I could ask John, Celia, Ted and Kate to keep your cameras on and your mics off. I've got 3 questions I'm going to pose to the panel to answer today. But obviously, if anybody else does have any questions, then we can pull them from the chat, and think Lacey, you'll be looking after those. We'll aim to finish just before 12 so that we can wrap up. So you'll have to talk fast, everybody. So my first question is, we collect huge amounts of healthcare data, but patients don't often feel the impact. What needs to change so that insight genuinely leads to improvement in care? And I'll open that up to the panel. Thank you. Celia, please go first.
Thank you. I think it's about sharing accessible data better. I mean, we've heard from the other speakers about this as well, But when you give people information about potential treatments and so on, I think you ought to be able to give them access to good data about that at the same time, not just when you ask them to sign a consent form, but when you first see them or before any other treatment. You could have a QR code on the letter that enables them to access other things and so on. And as Ted said, it's that combination of the appropriate narrative along with the data, because people are taking more responsibility for their data in this country now. Not everybody, but a lot of them. And we should make that easier for them so they can ask searching questions, which we really need them to do. When you have a patient who is a doctor themselves, they often ask you very searching questions, and we need to raise the health literacy level more broadly.
Ted.
Thank you, Rachel, and I totally agree with everything Celia just said. Can I just challenge the premise of your question? You said that patients don't feel the impact. I think we've seen in all three presentations that patients do feel the impact of a lot of this data. So there is an awful lot of benefit being delivered to patients because we're collecting the data, and I don't think we should shy away from celebrating that. But equally, as I said, and as Kate pointed out with her funnel graph and the outliers, that while the data overall is benefiting patients, there are problems there hidden beneath the data, and we aren't picking up those problems early enough. And I think that is an issue for us. So that problems are developing, and we tend to pick them up only when they become real crises. And actually, a mature safety system should be picking up problems very early on, so you can take action early on, and patients are not harmed, or you minimise the harm before action is taken. And I think that's really important. So what I'd say to you is that there's lots of data out there, but it's fragmented. Every bit of data is separate. Everyone has a silo with their data in it. HQIP has got a lot of data. NHS England has got a lot of data. CQC has got a lot of data. HSSIB has got a lot of data. NHS Resolution's got data on legal claims. The Ombudsman's got data on complaints. All that data is out there. Why don't we try and bring all that data together and actually analyze it as big data, as you would in any kind of major undertaking, to try and pick up that risk early on, to pick up the signals long before they're causing significant harm to patients. So I think there's real opportunities, but it does mean everyone working together and not us all just ploughing our own furrows, which I think is what we tend to do at the moment.
Yeah, we do sit very with tunnel vision, Ted, don't we? So it would be great to see that being achievable. Do you see that being achievable in the next 10 years?
Well, I think the advent of artificial intelligence gives us a chance to analyze data from different data sets in a way that is intelligent. I mean, it's very difficult without artificial intelligence to draw out I mean, doing it, using conventional systems, I think would be difficult. I think this could be one of the real benefits of artificial intelligence in our healthcare system, looking at all the data and actually identifying risk very early on.
Fantastic. Thank you. Kate, over to you.
Yeah, I was just going to say it needs to not just be a tick box, and it needs to be genuine reflection on the results. I understand that clinicians are busy and it can be hard, but people do need to sit down and look at their result and see what they can do about it. It's easy to justify results, I think. Occasionally I've heard people say, oh, but it's because our computer system doesn't do this, and that may be true, but there's got to be genuine reflection on results.
Yeah, totally agree with you. John, did you want to come in?
Yeah, thanks, Rachel. I guess it was just to say that even though we've got extensive data, I think sometimes we have to be quite specific in terms of what we're trying to address with the data. So what's the clinical question for the patient? The National Prostate Cancer Audit might be an example where over-treatment has been a major problem for many years, and that's now almost eliminated just by looking at data and showing it back and sharing that. Particularly, we've got a powerful patient lobby such as Prostate Cancer UK and Prostate Cancer Scotland and so on. So I think that's been useful, and the corollary was picking out men who've got high risk disease who aren't accessing treatment in parts of the country. What was the percentage for that? So sometimes really targeted. If you've got a good patient advocacy group, even better to help us drive the change, and hopefully the presentation of data back to clinical units. I think the action has to end up sitting back with the clinical service, doesn't it, in terms of addressing the variation.
Yeah, absolutely. Does anybody have any questions for the panel on that subject about the data that we collect and the impact? And Ted has raised a challenge with the question, and I always welcome a good challenge as well. So, and I think Kate is brilliant, because she's all actually said that, you know, the data is informing the patients and improvements are being seen. So I really welcome Ted's challenge. I just saw someone put their hand up, Celia. Can we bring them in?
It might be possible, but what we'd love to do is to be able to ask people to put their questions in the Q&A, because mics are automatically muted. Yeah. It could be what we've noticed is people are sometimes pressing the
reaction,
hand raised by mistake instead of reaction. And Jane, if I could just say, if you don't have access to the Q&A, you can pose your questions to us afterwards using the HQIP Contact Us box on our website. So that's also worth exploring.
I think it just popped it in the question and answer section. A more authentic approach and explanations are needed rather than a tick box approach, is what Kate's alluded to, as organisations are separate. Because of this, outcomes are separate when it needs to be holistic. Any thoughts on that from everybody? John, I think you're reaching for your unmute button.
Yeah, I mean, I suppose that's the golden thread that Ted started as well. It's not just about collecting data, it's about where does it go and how do we interact with it and how do we improve care. And I think where it's picked up on, and firstly, the data is checked and quality assured by organisations or individuals, and there's a genuine problem, then I'm stealing all of Ted's nuggets here, but the leadership's then key, isn't it? Who's leading that organisation and who's interested in it and who's seen it? And I think it's getting the data out, sense checking it, owning it, and interacting with it. Organisations, through our GERF rule as well, organisations become terribly defensive if the data doesn't look like what they think it should do. So if it's good data, they think it's excellent, the quality is perfect. If it's bad data, it gets questioned. So I think it's getting it into the organisation, using data for improvement. There's still a great fear, isn't there, of being an outlier, of being holding that responsibility, either as the clinician or as the management team. But yeah, thank you. See a few other hands up.
Yeah, Kate, I'll go to you first, because I think you had your hand up, and then Ted, definitely come over to you.
Yeah, just a very quick, it just reminded me of when I did the peer review visits as a parent rep. And at the time, I thought it was really interesting to hear. So this is where the team went into various hospitals, asked all the questions. And some of the information we got was somewhat scary, really, as to what the care was. But I have no idea where that then led and were improvements made, or did it just come to a bit of a dead end? So that is my worry. And that's slightly different, I suppose, to the actual audit data, but still information that we should be using.
Thanks, Kate. Ted?
There are two issues here. One is that we need to, and leadership needs to, sweep away these defensive reactions. We need to accept that the purpose of collecting data is to find problems. If the data is just telling us everything is all right, it is giving us no benefit. So actually, if you're not finding problems with the data, you're not using it effectively. And so it shouldn't be seen as a negative to find problems with the data. That is how you drive improvement. And John was just describing there perfectly Mary Dixon Wood's approach to comfort seating and problem sensing. And that if you've never read that paper, it's 2014 paper after the Francis report, it's an incredible paper, because she talked to 70 trusts and explored the culture in those trusts and differentiated between those that were problem seeking, they're looking for problems to solve, and those that just wanted comfort from the data. And we need to see data as a way of identifying problems that need to be solved, because there are always problems. You know, healthcare is never perfect. There are always things that we should be doing better. And if we aren't finding those things from the data is not really serving its purpose. But just come back to what I was saying a bit earlier on. We need to identify those problems early on, before harm has occurred, before people have suffered side effects of poor treatment or whatever. But also that creates a much better culture to deal with problems. Because if you wait for things to become a crisis, the culture becomes so defensive, it's very difficult to drive improvement. And so early detection of issues, and that's what audit can do. But as I say, audit with other data. Let's try and bring that data together to make ourselves much more sophisticated at identifying problems early on.
Yes, absolutely. And obviously being an ex-regulator myself, I know that the inspections and the things and the outline process can actually be very daunting for operational staff and leaders. Do you think that message about the defensiveness and no blame culture, do you think that message has really been conveyed and embedded into our healthcare systems? Because I know from the fact that when I used to go on site as an inspector, the fear it generates in people when you walk onto the site is still very apparent. How are we trying to navigate that and make it better?
Well, Rachel, you will have experienced, as I did. When I was at CQC, I used to go into organisations and talk to them about their problems, and you could sense straight away you were getting a defensive response. However hard you tried to be supportive, the response was defensive. Now, and with HSSIB, you go in to talk about problems, you get a very different response. Same people, completely different response, because we've got safe space. Anything they tell us is confidential, and they are much more open. It's very difficult because the regulator has a role, we have a role, and you can't just sweep that away. But having said that, we need to give people the psychological safety, the sense that they are not under threat when things go wrong, but they are seen as part of the problem, part of the solution, sorry. And I think at the moment, people feel if something goes wrong, they may be personally under threat. And as I say, one, we need to look at the culture and the way we manage it, but we need to pick up problems earlier so they don't become crises that are very difficult to manage.
And do you think, and again, I'm going to challenge you back now, Ted, because I've got surgeons in the room. Surgeons are often the hardest nuts to crack when it comes to sort of that transparency. And sorry, guys, sorry, but to put their hands up and say, yes, there are errors that we are, there are mistakes in our organisation. Do you think the culture in the clinician side of things, because I think being an AHP, radiographer is my background, I think we've kind of come on board with that no blame culture. But do you think our clinical clinician colleagues are joining us on that journey?
Well, our surgeons come in all types, and I'll allow the surgeons to speak for themselves in a moment. But I remember one surgeon I respected enormously. And if I needed an operation, I'd have gone to him at the drop of a hat because I thought he was incredible. Remember, he was talking about it, saying, look, my career could just hinge on my next mistake. And so we've created a culture in which surgeons can live in fear of getting things wrong. And then we expect them to behave well when we challenge them about their practice. That's not the culture we want. We want the thoughtful surgeon who is worried about what could go wrong to be celebrated, not the surgeon who, if you like, believes nothing ever goes wrong because they're infallible. I mean, the surgeon who believes they're infallible is the really worrying one. The one that's concerned about failure is the one that I have the greatest respect for.
Absolutely. John, Celia, anything from you around that?
I was just going to say, I mean, I think that's right. The problems we had with surgeons traditionally is where insight is lacking. So reflective surgeons, generally speaking, will address problems and do so. I think one of the disconnects we've had is that sort of the surgeon's holding the scalpel, therefore when things go wrong, everything sits with the surgeon. But of course, we know that perioperative care, anesthesia, the facilities that are available out of hours, cover at night, there's all sorts of things that play into surgical outcomes. But I think there's still a worry around accountability directly with surgeons and national consultant information, etc. So I think I keep coming back to the theme is data for improvement, isn't it? So that if you are an outlier, let's take the data, let's take it back, let's check it, let's see where the problem lies. And the problem may well not be in the operating theatre itself. It might even be patient selection, etc. So it's trying to normalise that. But I'll see if Celia, what's about that? I saw her raise her eyebrows.
No, I feel the same, John. It was always terrifying that I might mess something up. It always worried me. I always wanted to try to do better. It's a difficult thing to do, but it's so rewarding to be able to help people in that very direct way that one does as a surgeon. I guess that's what keeps us at it.
Yeah. Ted?
Just to go back, just when John was talking there, something that came to my mind. The problems are often system problems. They're not the problems with individuals, but the surgeon is, if you like, at the sharp point, literally in many ways, of those problems, and so they take it personally when the system fails. So it is usually not about individual competence. It's about the system in which people work. But we still can't grasp that. And I think surgeons often can't grasp that because they feel personally accountable for everything that happens to the patient.
Yeah, and I think that circles back as well to what you said, Ted, about having this whole system-wide view. You know, our audits span patient pathways. We've got a perioperative audit that now we have under the HQIP, and it isn't just about that single point in time for a patient of when a scalpel goes into somebody or medicine has been administered. It's about that end-to-end system and looking at it from an overall. So thank you very much for that, John.
Yeah, to agree with that, Rachel, there's been a lot of work done by Stephen Vickers, who's now in New York. I think that even if you track an individual surgeon for a lifetime, it's almost impossible to show that that individual is associated with higher degree than harm than the next person. And that plays into the fact that our care is the whole pathway from selection of cases through to post-op management. So I think it's about recognizing that. And so there will be variations, 50% of people are below average, so there will be variation, and it's how do we sort of get a rising tide to lift all boats? And I think the point we're going to make about this is taking the best to the rest. So where there is good performance, so not just focusing too much on where there are problems which we have to do implicitly, but where there is best performance, what's made that happen? And it's often leadership, actually. It's often clinical leadership. The skills we deploy are actually fairly generic, and a lot of what we do is fairly basic, and we've been trained for many years to do it. So it's when there's good leadership and whole pathway approach to improvement and working as teams, I think that's where we improve outcomes, rather than focusing on one individual will probably not improve the outcomes.
Yeah, no, absolutely. And it's a sad but true is a comment that we've just got in the Q&A about some people in operational delivery now still afraid to speak up due to fear of receiving detrimental treatment. And that's something we certainly want to discourage, which is why the system as a whole needs to work together to this non-blame culture and actually working and saying who's the best and why they're the best and learning from what they do as well. I've just noticed my little 5-minute flag come up. So I just wanted to say a huge thank you to the panel for this discussion. I know we've not gone into all of my questions, but actually they were all kind of interrelated, and I think we've answered most of what I was going to ask you. Celia, could I just hand over to you very briefly before you hand back to me to wrap up, just to say some final words this morning, please?
Thank you. I mean, it's been a really interesting thing to be part of, because not just because of the questions being searching, but listening to the other speakers as well. And there's still so much to be done, but the data points us in the right direction to move things forward. And therefore, continuing to use data at all levels, from ward to board, is really, really important. So I'd just like to extend my thanks to the other speakers and to the comms team, and you in particular, Rachel, for making it all work well today. Back to you.
Thank you so much, Celia. I really appreciate that. Natalia, could you pop the slide up for me? Just to wrap up. Thank you. So that brings this morning's event to a conclusion. I really would like to reiterate Celia's words and thank everybody for this morning's presentations, and to thank all of you for taking part in today's event and getting on board with the wider Clinical Audit Awareness Week campaign. It's been a real success and you've helped to drive that. You can find further information about HQIP's resources related to all of the topics that we've been speaking about all week on our website. But just to remind you of a few things, there is still plenty to look forward to this afternoon on the topics of eating disorders and CAAW services. And of course, we have our award presentation, and all of the details of that can be found on our website under the Clinical Audit Awareness Week page. Next slide, please. We'd also love to receive your feedback. Please can we ask you to complete the short form by scanning the QR code or accessing the form via the Clinical Audit Awareness Week page on our website. And again, it's a final thank you for me. It's been an absolutely pleasure hosting this morning. And I thank everybody for joining me, and I will be hosting this afternoon session. So if you have an appetite for that, then please do join me. Thank you very much.
Thanks, Rachel.